So tonight, Dr. Barry Ramo will be joining our keynote speaker, Dr. Schade. I want to tell you a little bit about the University Health Sciences before I introduce Dr. Ramo. The University of New Mexico Health Sciences Center is the state's only academic health center, a nationally regarded $1.7 billion enterprise that provides New Mexicans with the highest level of patient care, conducts groundbreaking medical research, and trains tomorrow's health care providers. The Health Sciences Center includes the UNM Health Systems, including UNM Hospital, the UNM Comprehensive Cancer Center, UNM Sandoval Regional Medical Center, and 607 clinics and health programs operating in more than 140 communities statewide. Dr. Barry Ramo is a cardiologist and founder of the New Mexico Heart Institute. He's had a long and rewarding relationship with the University of New Mexico Medical School, where he is a clinical professor of medicine and emergency medicine. Dr. Ramo is also a consulting professor of medicine at Duke University School of Medicine. He has been the medical director at GOV-TV for 25 years and writes regular health columns for the Albuquerque Journal. Thank you for coming tonight.
Well, good evening. I cannot tell you how much fun it is for me to interview some of the great people at the University of New Mexico Medical School and Medical Center. You know, we need great things in New Mexico, and I think people don't appreciate the magnitude of excellence that exists in our Health Sciences Center, and our speaker tonight really represents that. David is a distinguished professor of medicine at the University of New Mexico, and he started his career at Davidson in college in North Carolina, and then went to Washington University Medical Center in St. Louis. Interestingly, Phil Eaton, who ultimately became a great friend and colleague of David's, is that the relationship didn't take when he was the student and Phil was the professor, but when he came to New Mexico after being at the National Institutes of Health, where he began his research career, he met Phil. And that relationship has endured all the way till now. And it was an enormously productive relationship which helped David get his start. Now, I could tell you about David's unbelievable accomplishments, but you can read about those if you want to go to Wikipedia. What is so remarkable, I won't say much about the fact that he's written more than 500 peer-reviewed papers, which is, I think, some type of a record. The fact that he's trained literally hundreds of people, faculty members, students. He's not only trained them to be good doctors, he's trained them to do medical research. And in his own right, he really is a triple threat. He's an excellent clinician. He is a most admired teacher, one of the greatest respected teachers in the university, and his research, of course, is something he'll talk about, and something that we all in New Mexico can be proud of, that's brought in literally millions of dollars to support the many people. But one other point I want to make about him is that David has done this for four decades, and he's not slowing down. He still has a lab that's fully active with 12 or 15 people doing this, seeing patients every day. He is the model, I think, of successful aging that all of us want to emulate. What is remarkable, though, to me, and most interesting in talking to him and getting to know him, is the fact that he asks questions. But the difference between him asking questions and the rest of us asking questions is that he gets the answers. And I'll give you a couple of examples. In the early 70s, when David and I were just starting out, diabetes in its untreated state led to a state called ketoacidosis. And in that situation, there wasn't enough insulin. And if there's not enough insulin, you can't get that sugar into your cells, and the body starts making acid. This is if there's just no oxygen, in a sense. And so the patients had a very high mortality rate. Well, the logical treatment that most people would say is the way you would treat this person with high blood sugars is you give them insulin as fast as you could. Well, it turned out the mortality for this was enormous. So David asked the question, you know, we've been doing this all this time and it stinks. The results are awful. What's going on? Well, what they discovered was that the potassium was, that the insulin was interfering with the electrolytes in the system and the heart was stopping. So with that, they went on to change the way that the insulin was administered, and now there's a totally different outcome for people with diabetic ketoacidosis. And that's because he asked the question. The second question that he asked really had to do with the idea of an insulin pump. Well, in 1980, nobody thought about an insulin pump. So he first asked the question, could we stick a needle inside the peritoneal space where all the abdominal organs are and put insulin there and have it be absorbed into the body? He did the research to show that that could be done. And many of you who've been around here for a while will remember that the totally implantable insulin pump was placed in New Mexico in 1985. Now that has subsequently, as you know, insulin pumps are now ubiquitous, a little different style than they had at that time. The final point, though, that I would make is the one that intrigues me, because we always are asking questions. Is treating the cholesterol going to make any difference in outcomes? In 1985, the question was, does lowering blood sugar really make any difference at all? Well, David was one of the principal investigators in the DCCT, the Diabetes Complication Trial, which asked the question, if you get the sugars down, will it make any difference? Will it reduce the incidence of eye disease? Will it reduce the incidence of kidney disease? And the answer that they came up with was yes. That was a sea change in the way diabetics were trained. So many diabetics, because of that kind of research, still can see, still have their kidney function. That was seminal research. It was done almost 35 years ago. So this is really important. And now David has another question that he's going to ask. Can we prevent and treat heart disease? I'm going to let you come and have David answer that question. Thank you.
Thank you, Barry. I guess this is on. It's a little embarrassing. I could have written that myself. It's too many accolades. Tonight I want to talk to you about diabetes and particularly heart disease, because heart disease is the #1 cause of death in 2/3 of people with diabetes. It is a horrendous problem that over the last 10, 15 years ago, during the last 15 years, we know so much more on how to prevent it and treat it. And that's what I'm going to try to convey to you tonight. So my title is up there, Preventing and Reversing Heart Disease in People with Diabetes. These ideas that I'm going to share with you tonight are not all mine. I really want to thank Dr. Ramo and Dr. Eaton, who we've all been in discussions about this, and so a lot of these ideas are from those two individuals and many other people who have contributed to understanding heart disease and diabetes. Now I'm going to focus on heart disease, and it can apply to people without diabetes as well as people with diabetes. There's really no difference except people with diabetes get heart disease more frequently, but it's the same disease state, and we treat it the same. So keep in mind that anything I say about heart disease applies to both people with diabetes and people who don't have diabetes. Now, I have never been told here how to get to the next slide, so maybe we're stuck on this slide all night. So can somebody help me? Is there a button? I guess we're stuck with this slide. Well, this is a great slide. No, it's not really. Help! Nobody gave me anything to push. I'm sure there is something to push up here, Laurie. I don't see anything. Savior. Somebody who knows how to work IT.
Not really.
Oh, maybe this? It's probably this.
Yeah. There you go.
Okay.
There you go.
Well, I can use this. So why am I here tonight? Well, for two reasons. The first reason is your kind invitation for me to come talk to you, and I really appreciate that. I love to talk to people, and I love to talk about health. The second reason is a friend of mine gave me this article in the New York Times. It's their Science Times. They have a science section every Sunday in the New York Times. And my friend said they have a very interesting statement in there. And the statement was that it takes 10 years for a great discovery in medicine to ever get to the people. 10 years. And actually, it's interesting, I got interested in that comment, and the statement's actually incorrect. I went to the literature, and actually the average time for a great discovery in medicine, a vaccine, a preventive medicine, whatever, takes 17 years. 17 years to get to the people to treat their disease. So what I'm going to try to do tonight is shorten that time. That's why I'm here. I want to shorten that time because we have people every day dying of heart disease. We can't wait 17 years. We can't even wait 10 years. We can't wait 1 year to reverse that situation. So that's why I'm here tonight, to communicate to you what I think is something we can really do something about. Okay. So my first reaction to this 10 years, 17 years delay was, that's a really long time. But I began to think about it, and in fact is all great discoveries or new innovations take a long time. And here's an example. I actually went to the literature on global warming, and global warming was first announced by our government about 40 years ago. They put out a paper saying that CO2 in the atmosphere could warm the earth and melt the ice caps. So here is 40 years, and as you know, some people are still debating this. Even though the glaciers are melting, the polar bears have nowhere to sleep. So 40 years is a long, long time. But people, you, me, we don't like to change our ideas. And this is a problem when new ideas, which are really good, come around. So it isn't just medicine that takes a long time. It's really everything. And I'll show you another example of that in a minute. So what am I going to do tonight? What am I going to do tonight? I'm going to basically list for you what I'm going to do. First of all, I'm going to try to define what the crisis really is. That's the first thing. Then I'm going to try to convey how we can identify who may be affected by this crisis. Okay, and then I'm going to suggest how we can effectively treat it. Then, of course, the question that every politician asks, and everybody else asks because we all pay taxes, how much is it going to cost? And the final question is, which affects you and me and everybody else in this world, is who should actually be tested and treated? So those are my 5 goals tonight in a half hour or so of talking, and then we will have a question and answer period. Okay, so this is a fact. 2/3 of the United States diabetes population will die from heart disease. That's well documented and accepted, I think, by all authorities. This is an old photograph, or it's a diagram or a picture or a painting of the Black Plague in Europe that spread across Europe and actually killed about 45 to 50% of the population. And you can see there was no cure at that time, and basically people just died. They didn't know what caused it, they didn't know how to prevent it, and it was a terrible thing. But the interesting thing is, more people have died from heart disease in the United States than all the people who ever died in Europe over a century of the Black Plague. That gives you an idea of how many people in this country have basically died from heart disease. Now here's a little, this is true, and this is for people even who don't have diabetes, that 50% of the people in this room will die from heart disease. That is an accepted fact. If you just look at population, you look at death certificates, 50% die from heart disease. This is one of my favorite slides. It shows basically what addiction will do to you. I think when somebody gets chest pain and a heart attack, they usually say, take me to the hospital, take me to the emergency room. A smoker grabs his pack of cigarettes and says, Lord, can I have one more puff before I go somewhere? So it's an interesting thing because smoking is such a risk factor for heart disease. So you can see he's grabbing his pack of cigarettes because he's afraid he'll go to the hospital without it. Okay. Now here are some people that everybody in this audience knows. All right? And I want you to notice a couple things about these people, and I could show you slide after slide after slide of people that you know who died from heart disease. All right? But I want you to look at the age. Up in the left-hand corner, we have James, who died at 51. We have Michael, who died at 54. We have John Candy, who died at 43. And then we have Tim Russett, who, as everybody knows, he was a newscaster, et cetera. And he died at a young age also. The interesting thing about Tim Russett was that at the time that he died, for months and months, he was under the care of a cardiologist. He was on a statin. And the most interesting thing to me is 1 week before he died, he had a cardiac stress test, which was normal. And 1 week later, he dies. Now, he didn't have any symptoms. He just up and died. This tells you how sudden this disease can come on with no symptoms. No symptoms. It just comes on. And we'll try to understand why that is. Now, you may think that you're okay because you're not a TV star. So 2 days ago in the Albuquerque Journal, I saw this, and you can see I got it from the newspaper because it's not very clear, but here is Stephen, who at the time was the principal of the Royal Del Olso Elementary School in Albuquerque, and he's 53, he has a family, a wife on his right there, 3 children, and he died suddenly, no symptoms. That is a tragedy. And this happens all the time. This is the tragedy that we're dealing with. This is something that is in our community. We can't put it somewhere else. Let me ask you a question. Here's the question. I'm looking at all the people in the audience here. I took a picture of them. There you go. There's all the audience. How many of you have heart disease? What percent of you? I'm going to put them all together. I'm not going to pick on any individual. And I'm talking about people who have no symptoms. You have never had a heart attack. You don't have any chest pain. If you take all those people, and let's say the average age is 50. We have some people younger. We have some people older. 50. What percent? I'll ask this gentleman. What's your name, sir? Jack. What percent of people who are healthy, no symptoms, no history of heart disease in this room have heart disease? What percent would you guess? 50%. 50%. Okay, that's probably maybe what most people would guess because 50% of the people die from heart disease. It's not correct, but it's a good guess, Jack. It's a good guess. Give this man a prize. Okay, what is the answer? 80%. I can assure you, 80% of you in this room have plaques in your coronary artery. If I took people at the age of 60, it'd be 90%. If I took people at the age of 40, it would be about 75%. And that is because heart disease starts early in life. 20% of teenagers have plaques in their coronary arteries. This is not something that just occurs at the age of 60. This starts early on. So 80% of people in the audience have heart disease. Now, usually, at this point, I usually say, please say hello to the person next to you. See, find out who he is. And then after he tells you or she tells you, then you could probably say goodbye because that's the person who's going to die from heart disease. It's not going to be you. It's never you. It's always the person on your right. So you're okay. You're okay. It's the other person that's going to die from heart disease. So you don't have to worry. All right? Now, people who sit on the aisle have nobody to shake hands with. They're in trouble. But it's always the other person. So say goodbye to the person next to you because you've enjoyed the short time that you got to introduce yourself. All right. All right. So this is a crisis. There's no doubt it's a crisis. And there's no doubt we need to do something about it. Okay. How do I know that 80% of you have heart disease? How do I know that? I'm going to show you. All right. We have to go back a little bit to discuss it. What we're really talking about are 4 main arteries in your heart. There are 4 main arteries. You can see them up there, the right coronary artery, the left coronary artery, circumflex, and the left anterior descending. They have names, but those are the 4 big arteries that cause almost all the heart attacks. So those are what we're focusing on, and I'll show you why in a minute. Keep in mind, 4 arteries in your heart. Now here's what I was taught in medical school about 200 years ago. But unfortunately, it's still taught today. And here's what's taught. The idea was that you go to Kentucky Fried Chicken, you eat a bucket of extra crispy. Good, really good, I love that, good. The trouble is, some of that Kentucky Fried ends up, all that grease, you can tell there's grease because after you finished all the chicken, there's all grease on the bottom of the bucket. I'm talking a bucket. The idea was that the grease in the food would get in your circulation, get to your arteries, and form a clot, as you see up there. All right? That was the concept that I was taught in medical school. And if that's true, then, of course, the standard way of diagnosing that constriction, let's see if I can get this next one to come up, is what they call coronary angiography. This has been the gold standard for many years. And I'm not sure you can see this from where you stand, but there's a constriction up there in one of those big arteries, the left anterior descending, of about 95%, all right? And of course, this person's gonna have chest pain, angina, because you can't get enough blood through to your heart and you have pain. This was the gold standard. The problem with this test is, it didn't predict very well. It did predict a little, but not very well, future heart attacks. So you could fix that constriction, and then the person could still get a heart attack 6 months later from another part of his artery that you don't see constricted. So this was a big quandary for many years, and we now know why that's true. And I'm going to try to tell you why that's true. What should be taught in medical school now, and what has been shown, and I have to give a lot of credit to the cardiologists who've done terrific work in this area, to demonstrate that this, in fact, is how you get a heart attack. It isn't the other way. What happens is you have these cholesterol plaques in your artery, but usually they don't impinge on the lumen. As you can see right here, this particular plaque really is not constricting that lumen. But what it's doing, if you look closely where the arrow is, it's beginning to explode into the artery. In other words, it's opening up, all right, and letting the cholesterol into the artery, where the body then reacts with a big blood clot, and that's how that causes a heart attack. Just think of a pimple or some kind of abscess that you've had on your skin. How do you get rid of it? It explodes out, and it's much better. Drains. This drains into your artery, and it causes a blood clot. So we now know that this is the mechanism of causing heart attacks. But that being the case, you can see why coronary angiography would have a problem picking this up, because it's not constricting the artery. It's in the wall of the artery, and then it explodes. But there is other ways to do that. And of course, in this situation, there's no symptoms. You don't have any chest pain until you explode into your artery and you have a big blood clot. Then you basically have a major heart attack. So it explains why there's no symptoms. 50% of people never have a symptom. They never have a symptom. They just have a heart attack. Okay. If you don't believe me, look at this. This is a picture of a coronary artery that's been cut. And if you look closely, you can see all this yellow plaque. And except for the top, which has fallen in a little bit, it's not really making the lumen of the artery any smaller. And look at all the plaque all the way around just waiting to explode into that artery. So believe me that this is really what happens when somebody has a heart attack. Okay, so how do we know this? How do I know that 80% of you have heart disease? There's a really good technique that's been, and it's been the cardiologists who have used it over the last 10 years. And this is something that everybody is familiar with. It's called ultrasound. Because you've had it in different ways. You can see the machine off to the left there. You've had it when they want to know the sex of an unborn child. They'll do an ultrasound on the mother, and they can tell. You can use it for a thyroid. You can use it for a gallbladder. You can use it for lots of things because it's non-invasive. It's just sound waves that go in and out. And what they've done is they've been able to make a probe small enough to fit in your coronary artery. I'll show you a picture of that. Here it is. And if you look at this, you can see the blue is the catheter. This is a coronary artery. And you can see the little green there. It says ultrasound probe. That's how small it is. It's just minute. And it works very well. And you get a picture of the whole artery, including the plaque. Let me show you what a picture looks like when you get that. Okay. Here is the picture you get. So let's take a look at this picture. First thing is the probe. That's in the center of the artery. This is the whole artery. And you can see the probe is that dark circular area where the arrow is pointing to. All right? That's the probe. Let's look at another part. This is blood in the artery, this kind of mottled appearance. So you can see what the lumen area is there, and you can see blood in it. Okay. This is the plaque. This is the cholesterol plaque that nobody wants to have. What's in yellow is plaque. And you can see way outside the lumen of the artery with this technique. And these are plaques. And basically, this is the wall of the artery. So you can see this is a very good technique to see the whole plaque, whether it's inside the lumen or outside the lumen. And the cardiologists have done really tremendous studies using this to show certain things. The one thing I'm going to show you is regression. You could take this picture and regress that. You can get rid of all that plaque. And I'll show you how later, but I'm going to show you what it looks like now. Okay? Here's two pictures, 2 years apart. With treatment on the right, 24 months, the plaque has dissolved 25%. In 2 years, you can reduce that plaque 25%. You go 4 years, you can reduce it 50%. You can get rid of the plaque with appropriate treatment. We know you can reverse atherosclerosis. This technique proves it. And there's been, I can't tell you how many studies now in various populations, in diabetes, non-diabetes, showing reversibility of plaque and heart disease. You can reverse it. You don't have to die from it. Okay. Okay, that's all nice, but it's not nice for you and me because I don't want somebody sticking something in my coronary artery. It doesn't appeal to me. What if they miss and they go up in my head? Not good. So what you and I need is something in which they don't inject anything in you. They don't stick you with a needle. It takes real short period of time and it's cheap. All right? So that's what you and I need. All right? Luckily, we have that. It's called a coronary calcium scan. And this is where I give Dr. Barry Ramo all the credit. His institute has the technique to do it. I've sent hundreds of patients to him. So have other people. They've done about 10,000 of these in the last 10 years. And it takes 10 minutes. It's totally non-invasive. You get a little radiation. You get the same amount of radiation of living in Albuquerque for 4 months, background radiation. For being in here for 4 months is the same amount of radiation. It's practically nothing. All right? You go out in the sun, then it's the same thing. So it's called cardiac calcium scoring. It costs $150, and it tells you, it predicts very well who is going to have a heart attack. And so these investigators went into a community like ours, people who had no symptoms of heart disease, and they did calcium scores on people. Let me show you what they're actually looking for in this technique. all right? This is an amazing technique because you go in and you just lie down and they put some leads on you, EKG leads, and then this machine, between heartbeats, takes these slices, pictures, they're just pictures, totally non-invasive, doesn't slice up your heart. That's just for visual communication. Slices, and what are they looking for? Let me show you what they're looking for. They're looking for calcium in the coronary artery. And the reason there's calcium is because the body doesn't like plaques. The body doesn't like plaques, and it tries to wall them off with calcium. And it's very good at it if it has enough time. If it can get it before it explodes into your artery, you're safe. So what this tells you is that this patient here has a very high calcium score because the computer, this is computer-generated score. It's not me looking at this and saying this is good or bad. The computer will give you a number. It's called a score. And it goes from 0 up to 2,000. But most people at 2,000 aren't with us anymore. All right, and I'll show you why. But this technique, non-invasive, relatively inexpensive, 10 minutes, and is very predictive of future cardiac events. And this is what they're looking at. I'm just showing you at the bottom. This is a typical readout. You get a report. I, as a physician, and they send you a copy too, of your score. And you can see over there, they give you the 4 arteries that I pointed out, the 4 arteries, each have a score, and then they take this score and add it up. So I want you to remember, just for a minute, this score of 522. 522. And this is the score that this patient had for coronary calcium. And then if you ask the question, how long is this patient going to live? You can see this is how often you get a heart attack versus years. So if your score is 0, you practically never have a heart attack. If your score is 0, you do not have heart attacks. On the other hand, if it's 300, you can see within 5 years, 10% of you are going to have a heart attack. And of course, if your score is 500, which that patient had, which they don't even have on the graph because it would go straight up, patient probably would be 25% have a heart attack in 5 years. It's a very good predictor. It's the best predictor we have of future heart attacks. So the bottom line is we can tell who's going to have a heart attack and who needs treatment. Okay. Now, so how do we treat it? Let me spend a few minutes on how we treat it. Okay. First, what are we treating? Basically, we're treating cholesterol that's circulating around in the body. Now, cholesterol is an oil, and oils don't mix with water. You've seen, when you pour oil down the sink, it doesn't mix with the water. So the body coats the cholesterol with stuff to make it circulate around without clogging up the arteries right away. And it's called LDL. So when you see your doctor, you'll get a lipid profile. One of the things will be LDL, stands for low-density lipoprotein, but it's these balls of cholesterol that are basically circulating around that go into your artery and make the plaques. That's how it really happens. Okay, so this is what we are addressing. We need to reduce all these balls of cholesterol, basically to reverse heart disease. Okay, cholesterol is an interesting molecule. It's an interesting molecule. Why do they say that? It's interesting because it's one of the only molecules in your body that can't be broken down. You could make the pyramids out of that and they'd still be standing and look a lot better than they do today. Cholesterol is the ultimate molecule for stability. And it should be because it's part of all your cell walls. But you don't want too much of it. So cholesterol only causes 2 diseases in man. One is gallstones, and these are cholesterol gallstones. You can see what cholesterol looks like when it's a gallstone. And some people have had their gallbladder taken out because the liver secretes cholesterol into basically the into the biliary system, and is stored into this sac. And of course, when it's that big, those are not going to come out and they need to be taken out surgically. But what I'm interested in is the other disease, which is heart disease. When you have too much cholesterol, it causes heart disease. All right. Now, let's talk about diet for a minute. Diet's one of the most fascinating subjects relative to heart disease. I cut this out of the Albuquerque Journal 2 months ago, or a month ago, and it's kind of interesting. You sort of know what they're saying. This is Agricultural Secretary Tom Vizak, and then there's Sylvia Burwell from the Health Human Services. And what happened is, you may have read in the paper, the government came out this year with new standards of what people should eat. And they basically said, don't worry about cholesterol. Worry about the fat that you eat and what kind of fat you eat. And that's what they said. But the the Congress got so upset at it, they had hearings, they called these people in, and I'm sure Tom there is saying, it's not my idea, you go first. And she's saying, you're crazy, Tom, I'm out of here. Because nobody wants to sit before an investigative panel and be grilled. But here's the interesting comment, and I'm going to read it to you because you probably can't read it. This is part of it. It says, lawmakers from both parties express frustration about how the government recommendations have shifted. Nobody likes change. So they didn't look at the data. They didn't look at the evidence. They just didn't want change. They didn't want the government ever to change what they said. And these were experts that were saying this. It turns out the experts were right. Cholesterol is not the problem in the diet. But the legislatures wouldn't let them change. So you're asking why it takes 17 years for a major advance in medicine to get to the people. It's because nobody wants to change. Change is hard for everybody. Okay, so let's pursue this a little more. The question I always get when I see patients is, can I reverse it with diet? The answer is no, you can't. You can reduce the incidence, and you can reduce it with a diet this is called the Mediterranean diet. It's very high in unsaturated fats, the good fats. And in studies using just this diet, it's been shown that the incidence of heart disease, although substantial, is reduced from 50% to about 45%. So it is important, but it doesn't reverse heart disease, okay? And why doesn't it? And this is why the government was right in this one case. Probably the only case I can think of. That most of the cholesterol in your body comes from your liver. It doesn't come from your diet. The liver makes cholesterol like crazy, and you absorb it, and it goes around to your arteries. So what you really want to do is reduce the liver's ability to make cholesterol. And you do that by eating oils that are unsaturated. Now, what are unsaturated oils? Basically, any oil that's liquid at room temperature is unsaturated. So you can see at the top, peanut oil, nut oils, all these oils, peanut butter, etc., they all are made from unsaturated or have a lot of unsaturated oil. At the bottom is all saturated. That means there's no double bonds in it, and it causes the liver to make more cholesterol. So the government's actually correct. What you ought to focus on is the type of fats that you eat, not so much how much cholesterol is in your diet, because most of the cholesterol comes from your liver. Okay, let's move on and talk about, can we reverse heart disease with medication? The answer is absolutely yes. The pictures I showed you of reversibility were all done with medication. I'm not going to spend much time, 1 minute, on medication, but I want to point out that we have 3 different classes of medications now. This last one was just approved by the FDA in June. So we have 2 medications in that class. We have 1 medication in the first class and lots of medications in the statin class. So we have Zetia, which I think is totally underused, blocks your absorption of cholesterol that the liver secretes, has no side effects. and yet I never see anybody prescribe it. We have all the statins, which you know all about. I won't go over those, but they are generic. And then we have this third class, which basically helps deliver clear cholesterol out of the blood. I can tell you right now, with these three classes, I can reduce everybody's LDL cholesterol to less than 50. Why am I saying 50? Why am I saying 50? Because 50 is the number you were born with. You were born and your LDL cholesterol was 50. Everybody in this room was born with an LDL 50. I'll bet you nobody in the, well, that's not true. Few people in this room, but almost everybody in this room has an LDL cholesterol higher than 50. Why is that? Well, because when I was 5 years old, still had my LDL 50, my mother dressed me up for my birthday, said a big surprise, took me to McDonald's. I had a Happy Meal with all my other friends, right? I was happy, but my coronary arteries were very unhappy. And things just got worse after that. You know, then there was Kentucky Fried, and then there was this, and there was that, all this great food, and my heart just started to clump up. So basically, 50 is the number you were born with. That's the number. If you're at that number, you will reverse heart disease. All those studies I showed you that reverse heart disease, LDL is always below 50. Okay, so this is the number you should keep in mind. That should be your goal if you want to reverse heart disease. Okay. So, this is just, I don't have any stock. I don't have any grants from these folks. I don't have anything. But when a patient comes to me and I need to lower their LDL cholesterol, this is my prescription. This is my prescription. And the reason I use only the lowest dose of Lipitor, it's generic, it's atorvastatin, is that you get 75% of the effect of atorvastatin at the lowest dose. And all the side effects of statins are dose-related. So if you double the dose, you get double the side effects. If you double it again, but you don't get much improvement in LDL lowering. So I just use another drug, and that's Zetia, that has no side effects and blocks all the cholesterol absorption. I can get anybody here down below 50. Practically, in practical terms. This is really a great prescription with very, very few side effects. All right, so what's it going to cost? What's it going to cost? Let's ask the question a little differently. What is it going to cost if you don't reverse atherosclerosis? That's the same question, but a little different. Here's what it starts to cost. This is the standard treatment now. This is the standard treatment now to fix a constriction in your coronary artery that's causing you angina. It's called a stent. You can see what it looks like. It costs if you add up all the costs, hospital costs, doctor's costs, stent cost, it's $50,000. I know one patient with 5 of these. You just don't get one because you may have constrictions around your arteries. You end up with 5, $250,000. All right? That's what it costs if you don't take care of the problem. If you take care of the problem, you're going to be on some medications. You're going to have an improved lifestyle. But everybody here as a stent is on the same medications. They put all these people on the statins and the medications, but it's like closing the barn door after the horse has left. So it's no difference in the cost of the medications. It's just when you use them. So the cost is astronomical. That's why health care costs, that's why your health insurance seems to go up every year, because everybody here is paying for these. It's very expensive. So is your life worth $150? This is what I ask my patients. They come in because insurance doesn't cover this. Only in Texas. Texas, they cover it, insurance. But everywhere else in the United States, you got to pay for it yourself. So is $150 too much to save your life? Well, let me show you a couple people. People you know. This is Dave Letterman, 52 years old when he had the cardiac surgery, the stents, the bypasses. His father died the same age of a heart attack. He was lucky. About 50% of people die when they first have a heart attack, and 50% of the people don't. He was lucky. He survived. All right? All right, what about Bill Clinton? Bill Clinton twice has had to have cardiac surgery. Now, Bill Clinton has enough money to pay anything, but my question to you is, basically, you think either of these individuals would pay $150 to prevent all these surgeries? And I think the answer is obvious. What is your life worth? And I've had not one of my patients say my life is not worth $150 and deny getting a calcium scan, because you know what's going to happen. Okay, I've only got a couple more slides, and I'm going to end up with a question that you may be asking. I always ask, who should we test? Who should get a calcium score? All right, now this is somewhat up to the individual doctor. I'm going to give you my opinion, but it doesn't mean it's the gold standards. It doesn't mean it won't change as we get more data. But I'm going to tell you what I do. Okay. First, and I'm just talking about adults, we'll talk about age in a minute, who have risk factors for heart disease. Hypertension, big risk factor. Diabetes, big risk factor. Family history, big risk factor. Being a male, a risk, unfortunately. Being a male, we're stuck with. All right, some of these you can change, some of these you can't change. If your LDL is high, big risk factor. So forth. People with multiple risk factors ought to have this test because you can prevent the heart disease. Okay. This is a current feeling among many of us. There was just a recent study called the MESA study, took people who were asymptomatic in a community and said how many of these people would meet the American Heart Association guidelines for statin therapy. In other words, doctors would just put them on once they met the guidelines. The American Diabetes Association has a statement that all diabetic patients ought to be on statins. I think this is crazy. But that's what they say. If you go to their website, that's what they'll tell you. All right? I think if you look at the MESA trial, 50% of the people who were supposed to be on statins had a negative calcium score and should never be on statins. So my recommendation is before you start statins, you may not need them. You may be protected. There's a lot of genes we don't know about, a lot of protected genes. Get a calcium score. Save you from taking all those drugs for the rest of your life. So before I start statins on somebody, I get a calcium score. And finally, this is an interesting category because I've just recently had two patients, prominent, young, about 45 years old, males, who were very worried that they would die of a heart attack. One of them was 40, he was 40 years old, he had a brother, 35, died of a heart attack. His father died at a similar age of a heart attack. He was certain he was next. He was certain he was next. And he had trouble sleeping at night, he was worried about it, he didn't have any chest pain, but his brother keeled over without any chest pain. I did a calcium score on him, it was 0. 0. He was so elated, I can't tell you. So elated. And I was very pleased for him. Because I didn't have to start any medication. I said, you're not going to die. We'll repeat this in 5 or 10 years. But you don't have to worry about it. He was elated. And I just had one of the university professors came to me. He was getting chest pain at night. He was trying to prepare for the lectures, and he was getting all nervous, and he was having chest pain. It doesn't have to be heart disease. Could be esophageal spasm or lots of other things. He was certain it was angina. His wife said, go to the cardiologist. Go get tested. He says, I don't want to go. I don't want to find out. He was certain. I did it. It was 0. 0. He was so relieved, I can't tell you. It was the best $150 he ever spent. He's now sleeping well and having a good time. Not worried about it. Okay. This is my last slide. I like this slide for 3 reasons. One is I wrote the website. But that's one reason, but that's okay. The second reason is it has all the information. If you want to go there, you can copy that down, of everything I've said tonight, and more, and more. So if you're interested in more information or the kind of information I've been talking about, you can get it from this website. The third reason is if you have any questions, you can go to this website, send me an email through the website, and I'll answer you back. So I will answer all your questions. Just send me an email. There's a little spot. It says, put your question here and send it to me, and I'll send it back. So if you're interested in this topic and you want information, you can go to this website and get it. Well, I want to thank you for putting up with me on a topic that one of my favorite topics because I think can really help us all. I have a family history of heart disease just like everybody else does. My father had a heart attack. His brother died of a heart attack. So we all have family members who've had heart attacks. This is a topic that's very dear to my heart and something I think that this is what medical progress has done in the last 10 years. And now we need to get this information out to the patients. Out to the patients. And I can't wait 10 years. I can't wait 17 years. We're losing 500,000 people a year to this disease that's totally preventable and reversible. So this is a message I'm trying to get out to you tonight. And I really thank you for your attention. I know it's hard to put up with, particularly my jokes. Okay, thank you very much.
Now you understand, I think, something that's so important because for years we've been looking at risk factors and we say, well, diabetes doubles your risk, hypertension triples your risk, smoking doubles your risk. But the one thing that we never had, which we have now, is an anatomic substrate that tells you whether you've got the disease or not. And I think what's so exciting about what David is talking about is that we now have a way of segregating people who don't need treatment. So that, as you point out, if the score is 0, your outlook is good. Now, let me talk to you a little bit more about diet, because as you know, the guidelines have changed. The cholesterol guidelines that came out last year say that, look, just take a statin, 80 milligrams of atorvastatin, 40 milligrams of Crestor, and don't bother. As long as you get your cholesterol down 50% of whatever it was, that's fine. You don't need to measure it. What do you think about all these are the national guidelines that came out?
Well, guidelines change every year, and there are multiple organizations who make guidelines. So you can sort of choose your poison. I'm sure there's a taco somewhere that's recommending tacos for breakfast, I don't know. But the point is, I'm a big proponent of a good, healthy diet. It's something we all can do. No question it makes a difference. And it turns out that cholesterol usually is with saturated fat. So although they say don't worry about cholesterol, if you avoid saturated fat, you will avoid cholesterol. And over a long term, the diet, the amount of cholesterol and saturated fat you take in makes a big difference over a long period of time. But they're saying current recommendations from the government are that you should avoid saturated fats because then you really do avoid some cholesterol, but then your liver doesn't make more cholesterol. So I actually agree with the government this time that basically that's a good recommendation. But whether the guidelines get accepted by Congress or whatever, you can see there's nobody wants to change, and that's always a problem.
But there is a prevailing feeling, if anybody remembers the piece of bacon on the front of the Time magazine, it says butter, or the strip of butter, butter is back. And so there is this feeling that somehow saturated fats really are okay. And the Atkins diet sort of promoted that whole idea that that's acceptable. I think you would agree, the reason that we have this epidemic of obesity in part is the fact that we went to the low saturated fat diet and everybody started eating snack wells. And the result was that everybody's fat. What do you think about that?
Well, everybody's not fat, just me.
Just 60% of the people.
60% of us are fat. Basically, the term calories in equal calories out is important. It does make a difference how much you eat of anything. And then there are certain types of foodstuffs that basically, like raw sugar and Cokes and so forth, no question, they raise your sugar in your blood, and they sort of make diabetes a lot worse. So things that you eat, diet is really important, and we can all eat much healthier, and we all can do something. So I agree with you that there are recommendations, but they do change. And right now, I think we should all be eating a diet that's similar to a Mediterranean diet, but we all like New Mexican food, green chili and so forth, but I think we all can eat healthier than we do. So that's kind of my take. I think I'm a strong proponent of diet.
How many people in the audience are afraid of statin drugs? A lot of people. What do you think of that?
Well, it's unfortunate that they are. These are one of the great discoveries in medicine. And the reason I think people are worried about them, at least if you go to the internet, you read all kinds of terrible things. If you look at controlled trials, let me give you an example. The actual instance in controlled trials in which they have a blinded placebo of a serious muscle problem is 1 in 10,000. A lot of people say, I can't take statins because my muscles hurt. The problem is that muscles hurt in people who are not on statins. And it's very hard to tell if it's the statin or not. And when they actually take people who are, quote, they use a term, intolerant to statins, and they give them either a blinded dummy pill or a real statin, but the patient doesn't know, it turns out that the patient is almost always wrong. Because people routinely, they run up the stairs too quickly, let's say they exercise without warming up. People stretch muscles all the time if you think about it, and people do get muscle pains. The incidence is very, very low. And unfortunately, that's one of the things you read on the internet, how it causes muscle pain in everybody, and in fact, it really doesn't. So
Right,
there are
there's
other
also the
signs.
misconception that it causes dementia. There's absolutely no data to show that. There's this perception that it somehow damages your liver, and actually the government has told us we don't even need to measure liver enzymes anymore. They are very safe, and they are very effective, and I think the key to this whole discussion really is that a lot of people are taking statins who don't need them, but a lot of people who need statins aren't taking them, and this is the way to make the differential diagnosis, determine whether they do or do not need them. We can take some questions from the audience. If people have questions, we have some microphones here, and we're happy to take them.
I have a question here.
Sure.
How long do you think it's going to take insurance companies to have a calcium score on anyone they insure?
Well, as I mentioned, I think the only state that, you mean have the insurance company pay for the calcium score?
No.
Oh.
Take the score and judge if you're going to get insurance.
Oh,
You mean how long will they look at the calcium score and then make a decision?
If I come in
right.
to get insurance and I'm 60 years old and they say we need a calcium study and my calcium study is 300, they say I'm sorry, we're not going to insure you.
Well, I don't know the answer to your question. I don't work for the insurance companies, but it's a very good question. I can't answer that. I just can't tell you that.
well, I mean, that degree of paranoia is appropriate. You can't trust them. But really, I'd be more concerned when they draw your blood for cholesterol that they're looking at your DNA and see if you've got anything there. That, we know most cancers really have a genetic basis, and probably, and David will tell you that a lot of the diabetes and the insulin resistance have a genetic basis. That's a great question. I don't know how we're going to resolve that, because once they start looking at that, you can bet they'll figure out a way to charge you more.
Exactly, or not insure you.
Well, just to point out that the federal government can pass a law saying they can't do that. They've done that for genetic studies. Right. They're not allowed to go into your genome, even if they wanted, because you can get a genome just with a blood test. Right. So the federal government passed a law that that's illegal. So they can do the same thing with a calcium score, with any other kind of test.
Next question.
I have actually two questions. Is high cholesterol hereditary? And would you please talk about metformin, the use of that over the years for diabetes? Is it true that it now has if you take it for a long enough time, that it will affect your heart? Is that true?
Well, let's take the first question. Is high cholesterol hereditary? I think that was your question. And the answer to that is absolutely yes. There is no question that many of us are born with a gene, which if we add the diet that we eat, the gene kicks in. In other words, there's an environmental influence on top of the gene and gives us high cholesterol, high LDL levels. So this is called part of the family history. You have a positive family history, it's undoubtedly a genetic problem, and we all make it worse with the types of saturated fats that we eat. So basically the answer to that question is yes.
Let me just comment, though.
Sure.
People take solace in the fact that they don't have any family history of heart disease or their cholesterol is normal. I have plenty, the vast majority of people who have heart attacks have normal cholesterols. What is normal is 50, not 110. And so what people believe, well, my cholesterol is normal, I really don't need to treat it. After a heart attack, 50% of the people who have heart attacks stop their statin drugs within the first year because they don't believe that their cholesterol is high enough to need treated. What was the second question? About metformin.
Oh, metformin. Well, I know of no, metformin is very interesting. It's been used for many years, and it's a very good drug for patients with type 2 diabetes, no question about it. In fact, right now the National Cancer Institute is providing funds for us and a lot of other people because it looks like it prevents cancers. I don't know any data, and I'm going to ask Barry because he may know data, that it actually has a detrimental effect on your heart. So I'm going to pass that question to Barry.
Actually, you raise a great question, though, because David really is knowledgeable about this. There are two exciting classes of drugs now that are available that are used for diabetics that are, I think, are just unbelievable. You might just mention that because a lot of the people here are interested in diabetes.
Well, what is really, let's say, propelled the pharmaceutical companies into type 2 diabetes is the number of people who have it, so the marketplace is huge. And almost every year, we're seeing a new class. And the most recent interesting class is called an SGLT2 inhibitor, but what it does is it blocks glucose absorption in the kidneys. So if you have a high glucose in your blood, you actually pee it all out and your glucose comes down. What Barry may be referring to is just an article last week in the New England Journal showing that it reduces cardiac deaths. It has some protective event. Now, it does lower blood pressure. It lowers weight, and so it has some good things on risk factors. So that class of drugs has now become fairly popular. The other class of drugs, which he's probably referring to, is when anybody eats a meal, there is a chemical in your terminal gut that is secreted that makes your pancreas secrete all this insulin. And so now this is called a GLP-1 agonist. You can forget the name, but what it does is it does some very nice things. It makes your pancreas secrete more insulin. It suppresses your appetite. It slows down your gastric emptying so you feel full all the time. And it actually suppresses a chemical named glucagon, which is used to raise blood sugar. So we have two really exciting classes. We have some other classes, but we have these two that we've just seen in the last 5 years that really make a difference now in the treatment of type 2 diabetes. So it's very exciting. Diabetes, we're getting more and more treatments for diabetes that are very exciting.
But think about what I said at the beginning. David's seminal research in the mid-'80s asked the question, is lowering the blood sugar going to change the outcomes? And now we have data that not only does it affect the eyes and the kidneys, it affects the heart and the cardiovascular system. Yes?
Do you need a doctor's referral to have one of these calcium tests? And is Dr. Ramos, is it your place, the only place that it's done here?
I think right now we're the only place in the state that does it. We've done them. We have a Dr. Brendan Cavanaugh in our group who took a special year of fellowship when he came to join us 10 years ago. No, you can get it without an appointment or without a doctor referral.
Thank you.
Let me just make a comment. There's only two cities in this state in which you can get a calcium score. One is Albuquerque at the Heart Institute, and one is Las Cruces.
Oh, is there Las Cruces? I didn't know that.
There's only two places. You can't get it in Santa Fe. They used to do them at St. Vincent's Hospital in Santa Fe, but nobody ever ordered it, so they just stopped doing them. This is not a complicated test. It's just that none of the doctors order these. So they could do them anywhere they want, basically. They have a CT scanner. But if nobody orders them, they don't bother doing them. So right now, there's only two places in the state who routinely do them.
But a good example is, let's say I see a 60-year-old woman and her cholesterol is, LDL cholesterol is 130, and our guidelines would say we have a new risk factor score. Virtually everyone over 70 should be on a statin based on that score. that person, if they get a coronary calcium score and it's 0, and it's like a pregnancy test, you either got it or you don't. If you got plaque in there, I don't care about the numbers as much as you. If you got it, you're pregnant. And that means you need to exercise, diet, everything you need to do. And David will tell you that it is a big motivator to find out that you've got the problem. Yes, ma'am.
I've got 2 questions. One is you've talked a lot about LDL tonight, and for myself a number of years ago, because I've had a high LDL for a long time, it was evaluated and I was told that it is fluffy and buoyant LDL, and therefore because it is fluffy and buoyant, it's not atherosclerotic and I don't have to worry about it. And so I'd like your thoughts about that. And the other question is, if you have a calcium score and it comes out at 0, and in the ensuing years you end up with being diagnosed with diabetes, with type 2 diabetes, even though there's no other risk factors, what is the trajectory then of a calcium score? Is it likely that in another 10 years your calcium score would be different because of the diabetes?
Well, I can address that, and so can Barry.
Those
But
are great questions.
I can tell you what I do. If your calcium score is 0, and there's always a reason I've done it, somebody has risk factors, I repeat it in 5 years. And if it's still 0, I repeat it in 5 years. It's just like a colonoscopy. You get done every 5 years. You get certain tests done every 5 years, because then you can jump in and treat it. But if it's 0, you don't have to treat it. So if you have more risk factors, you're more likely to develop calcium, but then you treat it. So it's one of these ongoing things that's non-invasive, takes 10 minutes, saves your life.
But what about the fluffy versus
Okay,
the
so
highly
the picture I
oxidized?
showed you of LDL, that was stylized. They all look the same size. But in fact they're different sizes. Some are bigger, and they call them fluffier, and some are smaller. It turns out the smaller ones go through the artery wall easier than the big fluffy ones. But don't be fooled, the big fluffy ones can also cause plaques. So if you have a high LDL, you need a calcium score, and then if it's positive, you need therapy. Don't let the fluffiness interfere with the diagnosis.
Now, I have to tell you, I have a different view of this. I think you get calcium score once, and I think David and I have talked about this, we really don't know the age to start. Because a 40-year-old person, it's unlikely that they're going to have calcium. They may have plaque, and we know that they do. So I don't do that, but I'd sort of look at the age of the patients. I don't do sequential. If they're 0, if you're a 60-year-old woman and you're 0, your chance of having a heart attack in 15 years are 0, or almost 0. It's a bigger chance you get hit by a car. It is very cardioprotective. Now, the question about diabetes, I think, is important. If you become diabetic, does that change the equation?
Well, certainly it does. Diabetes is a very significant risk factor for cardiovascular disease. And so it's something, unfortunately, that you want to get treated also, because treatment, it's been shown in a number of studies, keep your glucose normal with treatment, you have much lower risk of heart disease.
Do you have a question?
You talked a lot about being able to reverse heart disease by using medication and not being able to reverse it using your diet. Could you speculate a little bit or talk a little bit about exercise?
Well, I can do it, but Barry's really the expert. Exercise, if there's a number of studies in very good journals that shows that people who are physically fit and exercise have a lower rate of heart attacks and heart disease. No question. No question that exercise is good. To me, it's not really clear what the mechanism is, but it's very clear that exercise is beneficial. So I think exercise is part of healthy lifestyle. Now, I'm going to turn it over to Barry because
I love your question.
he knows a lot about it that I
I'm
don't.
a fanatic about it because, we're not just interested in preventing heart disease. We're interested in preventing dementia. And probably a lot of you people think, like I did until I really got involved in looking at the literature, that dementia is one of those things you can't do anything about. It's Alzheimer's, and it's going to happen to you. That's wrong. About 50% of the patients who are demented have vascular dementia. And vascular dementia is the same problem that we have here. And I always tell my patients that what's good for your heart is good for your head. There is data now to show that you can improve cognitive function. There are substances that are called nerve growth factors that are secreted by muscle that will actually cause the production of new brain cells. There's overwhelming data that you can improve cognitive function with this. As far as the heart's concerned, I think exercise is critical. It raises your HDL cholesterol, it lowers your blood pressure, it shrinks your waistline. There's every reason for people to exercise. But I'll tell you, it's not the whole answer for sure. And I think the kind of diet that you eat, which is a more plant-based diet, is really important as well.
Thank you.
Well, I think we've got
Is the ultrasound of the coronary arteries the same as the calcium score, or is that a completely
I'm gonna let
different
Barry
test?
No, that's the ultrasound of the coronary arteries is where, as David shows you, go in, run a catheter up into the heart, and you actually put an ultrasound probe inside the artery and look at that lumen. And the studies he's talking about are so important because it's the first time anybody's actually shown anatomically that you can get that plaque out of those arteries. And, you know, that should give everybody hope. That means you get on the treadmill, you eat the right kind of diet, and if you need a statin, that you take a statin. I think probably, we'll take one last question.
But is the ultrasound of the coronary arteries give you the same score as the calcium scan, or are they two different things?
I'm sorry.
They're two different things. Another calcium score just measures calcium. The ultrasound doesn't count calcium at all.
It won't do anything about calcium.
No,
It won't
it's-
be a factor.
And we don't recommend it for the ultrasound
But
because it's too
understand
invasive.
that calcium is actually inert. What is not inert is that fat in that artery becomes inflamed and like a pimple just ruptures. That's why 50% of the time, if you do an angiogram like Tim Russert or you do a stress test, they don't have anything. 50% of heart attack, 50% of the first symptom of this disease is either sudden death or a heart attack without any warning at all. So it's imperative that we figure out a way to make a diagnosis that you got the problem earlier and do what David said about preventing it. Does that answer your question? Yes.
I recently read a study that stated that if you are diagnosed with type 2 diabetes and you're not overweight, that you have twice the risk of having heart disease or a heart attack than someone who maybe is overweight. And I was wondering if you agreed with that statement or if you've heard that and why that might be. And then also why diabetics have such a risk of heart disease. Is it the connection with the liver?
Good question.
Let me address the first question. There was an article that came out and coined the term, I'm not sure if it was the New York Times or a medical journal, coined the term healthy obese because they did what showed you. They took some thin diabetics, some obese, and showed that there was a group of obese diabetics, patients, that basically had less heart disease than those who were thin. The problem is when that study was dissected, excuse me, what it turned out was the risk factors in the group of obese patients that had very little heart attacks, they had very little risk factors. In other words, their blood fats were low, they didn't have a family history, they were overweight, but they didn't have any other risk factors. So it really turned out is how many risk factors you have. Now it turns out that obesity causes insulin resistance, which is a risk factor. But if you have no other risk factors, you're probably okay. It's the multiple risk factors that add up. And the second question I think you had was, why does diabetes increase your risk for heart disease? And that's a very good question. And people have really talked about that, done experiments. What we know is that high sugars do things to your arteries unrelated to fats. In other words, what they do is, and this is what everybody with diabetes gets tested every year, is called a glycosylated hemoglobin. Sugar sticks on everything. You know, it's sticky. And it's sticky in your body. And it sticks on all your proteins. And it sticks on everything. And it makes them so you can't, for example, move your hands like this. So patients with diabetes have what they call a stiff hand syndrome. So they can't do this. So high sugars by themselves cause changes in the artery. And they also do what Dr. Ramo just referred to, is they increase inflammation. And inflammation gets all these cells in there that makes things worse for the plaque. So there's lots of reasons that diabetes can cause heart disease. Separate. Usually a lot of diabetics have normal LDLs, but they still have more heart disease. So it's certainly more, but they also have, diabetic patients tend to have more hypertension. So it's the risk factors add up. So you have to look at how many risk factors you got.
So I think that we are going to conclude. I'd like to thank Lori Peterkin, who is from the Health Sciences Center, who really arranged all this and has arranged the other lectures. You did really appreciate that. And thank you all for coming. I think you've got a new insight into a disease that is killing, the #1 killer in our country, but also the idea you can leave with a very positive message. There is something you can do to change the outlook of your life and your family's life if you change your behavior and also do what you need to do to find out if you've got plaque in your arteries and treat it accordingly. So thank you very much for coming.
Thank you all.
Thanks, Lori. Thank you.